Good afternoon, everybody. This is Laura Young from the CPAN program. My apologies for the technical difficulties in today's presentation. I want to quickly introduce your presenters today. Today's CME comes to us from the psychology internship program here at UT Health Science Center in Tyler. We have two interns presenting today under the guidance of their faculty sponsor, Dr. Carli Ross Young. So Dr. Ross Young is a native of Maryville, Tennessee, but relocated to Texas as an undergraduate student and completed her undergraduate and graduate training in clinical psychology at Baylor University in Waco. She completed her predoctoral internship and postdoctoral fellowship in clinical psychology with the University of Texas Health Science Center at Houston, Harris County Psychiatric Center. Her areas of interest for clinical work and research include working with adults and children, adolescents and adults with serious mental illness, substance use disorders, trauma-related disorders, and members of the LGBTQ community. She also engages in program development, program evaluation, and clinical outcome research. For Carli Salsberg, who is one of our presenters today, Carli grew up in Atlanta, Georgia. She moved from a couple of hours south of Atlanta for her graduate training at Georgia College and State University, before returning to Atlanta for her graduate training in clinical psychology at Mercer University. Carli is currently completing her predoctoral internship at the University of Texas Health Science Center at Tyler, where she participates in a wide range of clinical rotations through the hospital. Carli has received and accepted an offer for postdoctoral residency position at Jackson Health System in affiliation with the University of Miami. Miller School of Medicine, where she specialized in adult consultation and liaison behavioral medicine. Carli's primary area of interest is health psychology, particularly comorbid medical and psychiatric issues, obesity and weight management, diabetes, and eating disorders. Outside of work, Carli enjoys exploring new areas and restaurants and spending time with family and friends. And our last presenter is Olivia Sodarth, who was born and raised in Jacksonville, Florida. After completing her undergraduate training in psychology at the University of North Florida, she relocated to Atlanta, Georgia to pursue graduate training in clinical psychology. Due to an exciting and unexpected turn of events, she moved to Chicago to complete her graduate training at the Chicago School of Professional Psychology. Olivia is currently completing her predoctoral internship in clinical psychology here at UT Health Science Center in Tyler with a primary focus on health psychology. Olivia will be completing her postdoctoral fellowship training at the University of Florida, where she will be specializing in health psychology and behavioral medicine. Her areas of clinical and research interest include personality, neurocognitive, and health assessment, working with adolescents and adults with a wide range of psychopathology, and the transgender and gender non-conforming population. Outside of work, Olivia enjoys participating in outdoor activities, exploring new places, and trying local restaurants as well. So I will turn this over to our presenters today. Thank you for your patience as we work through some technical difficulties on my end. So I will hand this over to our presenters. All right, so are you able to unmute yourselves? It looks like you're unmuted. All righty, we'll just take a moment.
Laura, maybe she needs to turn her microphone up.
That could be. Carli?
Does this help?
That helps a little bit, but it's still not loud.
All right, how about that?
That is better.
Okay, then we're going to talk as loud as we can.
That's great. Thank you.
Thank you for those introductions, Laura. My name is Olivia Sodarth, and this is Carli. We're so excited for everybody to be here today so we can present on motivational interviewing. It's something that we both personally are very excited about and use within our clinical practice probably on a daily basis. And we think that it can be beneficial across all of them. So our three objectives for the presentation today are to define and identify the primary elements of motivational interviewing, improve familiarity with MI's brief action planning strategy, and then discuss how to incorporate brief action planning in primary care and pediatric medical settings. So what exactly is motivational interviewing? MI is a technique used to enhance a patient's intrinsic motivation to change by exploring their ambivalence about a desired goal in a patient-centered manner. It involves helping patients identify a clearly defined target of change by first asking permission and then avoiding any use of confrontation or advice giving. The spirit of MI is what makes it a truly unique approach. It's centered on the following four elements: partnership, acceptance, compassion, and evocation. In contrast to more traditional medical approaches that have historically relied on confrontation and advice giving, MI is centered on the patient's autonomy, collaboration, and evocation of their ideas regarding change. This perspective assumes patients have the wisdom within to be able to change and works to uncover individualistic patient strengths and resources rather than probing for deficits, weaknesses, or limitations. Studies have shown that MI has been effective in improving a wide range of behaviors often seen in primary care settings. In fact, a whopping 80% of studies have shown that MI outperforms advice giving. Research has demonstrated that 3 visits or less can improve health behaviors, making MI an ideal choice of intervention in primary care settings. For children and adolescents specifically, MI has been shown to be effective with a variety of behavioral health concerns within a pediatric setting, including health-related concerns like obesity, STIs, disordered eating behaviors, substance abuse, including alcohol, tobacco, other drugs, and vaping, behavioral concerns such as improving school performance and attendance and reducing violence, and lastly, treatment adherence, particularly with chronic illness management and medication compliance. Also important to discuss are times when MI is contraindicated. Absolute contraindications include when there's immediate risk of harm to self or others, including cases of suspected child abuse and neglect, homicidality or suicidality, and individuals with moderate to severe cognitive impairment. Similarly, a child's developmental level must always be taken into account because one has to possess at least a baseline of operational thinking, which is usually said to develop around the age of 7. MI is useful in addressing both the why and the how of change. Although both components must be taken into account for every patient, individualistic patient needs must be understood and respected. It's also important to recognize that healthcare providers often focus only on the how of change, without addressing the why. This can lead to a patient's failure to achieve his or her goals. Patients are more likely to change problematic health behaviors when the provider elicits their personal reasons for making a change. Change talk is when a patient makes statements that lean in the direction of change. Situations that may indicate the presence of change talk include a parent who is apprehensive about vaccinating their child, might make statements such as, "I know my child should get vaccinated," or "My partner and I are really interested about learning more about vaccine side effects." Another example is a teenager who's been vaping and is wanting to change just to get his parents off his back. Change talk is different than sustained talk, and patients may use sustained talk to indicate their desire to stay as they are, so they're not quite ready to make that change. Situations that may indicate the presence of sustained talk include a child telling you that they won't eat vegetables under any circumstances, an adult telling you that they'd rather die happy than quit smoking cigarettes, or a teenager who tells you that they don't want to wear a condom because it doesn't feel as good. A clinician who hears change talk can use MI to help the patient move toward commitment to change and take the necessary steps to do so. Next, it's important to discuss how to incorporate motivational interviewing principles into practice, which can be done by asking open-ended questions, affirming the patient, using reflective listening skills, and then summarizing, which gives us the handy acronym OARS. So open-ended questions serve to elicit patients' internal motivations for behavior. These are different than closed-ended questions that typically result in a response of yes or no. The simplest open-ended questions begin with what or how. So an example of an open-ended question includes, tell me about concerns you have regarding your high blood pressure. Or, I wonder what would make it easier for you to quit smoking. Or lastly, tell me about how bedtime goes. So next, affirmations are statements that provide positive feedback about goal-oriented behaviors or personal characteristics, further reinforcing autonomy and self-efficacy. Examples of affirmations include, you have great ideas about how you can eat healthier, or it took a lot of courage to share with me what's really been going on at home. So the R, reflections, are statements that demonstrate that the provider understands the patient's thoughts and feelings. Sometimes this means taking a guess about what the person means. There are different kinds of reflections, and the first one is simple reflections, which include repeating and rephrasing the patient's statement. For example, you don't plan on taking your medication anymore. Next is the complex reflection, which include reflections of emotion or meaning. So an example of a complex reflection is, I hear that it makes you angry when your mom tells you to keep taking your medicine. Third, amplifying reflections add meaning or emphasis to what the person said. An example of that would be, you would rather stop taking your medicine, even if it might result in you getting sicker. And lastly, double-sided reflections, and my personal favorite, they acknowledge sustained talk and integrate it with previously identified change talk. So an example would be, you're feeling concerned about the possibility of needing medication for the rest of your life. And you've noticed that your mood significantly improves when you take it consistently. So the last part of OARS is summaries, which are succinct and strategic integrations of the conversation that was previously had. They serve to clarify mutual understanding and get feedback from the patient on what's been discussed. Summarizing can also help the provider make explicit any ambivalence and use it to develop discrepancies that make the positive value of change more concrete. So an example of a pretty good summary is, so far we've talked about eating healthier and exercising more. You wish you could do both, but it's been really hard. Some of the plans you've made in the past didn't seem to work, and I'm wondering what kinds of new ideas you can come up with today to change that. So we wanted to provide some examples of case studies that use MI in various developmental stages throughout the lifespan. And we're happy to provide this article that we adapted the information from if anyone is interested. But just quickly go through one example of how MI was used with the mother of a newborn. So Sarah is a 28-year-old first-time mother whose 2-month-old son has been breastfeeding exclusively until the past 2 weeks, when she had to return to work full-time as a school teacher. So she's giving him 2 bottles of formula in addition to breastfeeding 6 times a day, which is unsustainable. She's ambivalent about how much longer she can maintain this, but believes that she should be able to in order to give her son the best nutrition. To assist Sarah in enhancing her commitment to breastfeeding, a provider could ask open-ended questions about what she currently knows about breastfeeding, about the advantages and disadvantages of breastfeeding. In addition, the provider could reflect her comments using double-sided reflections and then explore solutions to past barriers to breastfeeding. Lastly, a brief summary regarding what was discussed and how Sarah plans on proceeding will help to highlight her ambivalence and encourage her in the direction that she wants to go towards change.
Okay, so now we're going to talk a little bit about brief action planning. Brief action planning is a highly structured, patient-centered, and evidence-informed self-management support technique that's based on the principles of motivational interviewing. And what's great about it is that it can be easily implemented by medical providers and only takes about 5 to 10 minutes to do. Brief action planning should be used when a patient is ready to take action in making a change. So this is when the patient and provider move from a discussion of whether to change to a discussion of what and how to make changes. So here's a general overview of what brief planning looks like. It involves 3 core questions and 5 skills. So the first question is there anything you would like to do for your health in the next week or 2? Upon asking this question, you will get one of the following responses. Either the patient has an idea of what they want to do, they are unsure of what they want to do, or there might just be nothing that they want to do at this time for their health. In the spirit of motivational interviewing, if the patient says that there's nothing they want to do at this time, we accept their response and don't push it or try to influence them. We can, however, ask permission to ask this question again at their next visit. If the patient says that they are not sure what they want to do for their health, we offer a behavioral menu, which is skill number 1. So again, using the spirit and framework of motivational interviewing, we ask for permission to share some ideas from other people who are working on something similar. So if they give permission, you would share 2 or 3 brief ideas. So for instance, you may say something like, some people want to work on getting more sleep or increasing physical activity. Do any of these ideas sound like something you would like to do, or have you thought of something else? You can also be more specific with your behavioral menu, and you can say something like, other people who want to have a healthier diet have worked on drinking less juice, eating more fruits and vegetables, and drinking more water. Do any of these sound like something you are interested in doing, or is there something else you've come up with while we've been talking? So once the patient has an idea of what they want to do, we move to the second skill, which is helping them create a smart behavioral plan. So again, we want permission from the patient to be able to do this. And a SMART goal is a goal that is specific, measurable, achievable, relevant, and timely. So for instance, if a patient's goal is to increase physical activity, an example of a SMART goal would look something like, I will play basketball at the park by my house on Tuesday, Friday, and Saturday for 30 minutes starting this Tuesday. An example of a goal that would not be considered a SMART goal would be something like, I will play basketball more. Once they've created a plan, we want to elicit a commitment statement, which is the third skill. So the commitment statement would sound something like, just to make sure we understand each other, would you mind repeating back to me what you decided to do? The act of repeating back organizes the details of the plan in the person's mind and may lead to an unconscious self-reflection about the feasibility of the plan, which then sets the stage for question 2 of brief action planning. So question 2 of brief action planning asks, how confident or sure do you feel about carrying out your plan on a scale from 0 to 10, with 0 being not confident at all and 10 being the most confident? If the patient's confidence level is less than a 7, we want to move to skill 4, which is problem solving. So let's say a person said their confidence in their ability to perform their plan is a 4. You could say something like, a 4 is higher than a 0. That's really good. But we know that people are usually most successful when they come up with plans where their confidence level is a 7 or higher. Are any things that you might want to do to raise your confidence. Or if you have any ideas of things you could do to raise your confidence. If the patient says no, again, we could do something like a behavioral menu. So this would maybe be suggesting that the patient could go twice a week to play basketball instead of 3 days a week, or maybe reduce the amount of time they spend playing basketball each time. And then once you find one that they like or they are able to come up with their own, you then want to recheck their confidence level. And if it's a 7 or greater, you can move on to the next step, which would be question 3. And in question 3, you would ask, would it be helpful to set up a time to check on how things are going with your plan? So checking on the plan can be really beneficial because it increases patient accountability and confidence. When the provider checks in on a plan with the patient, he or she will first ask, how did it go with your plan? The patient may respond to this question in one of 3 ways. So the patient may report that they did not carry out the plan, in which case you want to let them know that it's not uncommon for this to happen. And this could also be a good time to use an open-ended question about what may have gotten in their way. The patient could have also reported that they partially completed their plan, in which we want to recognize their partial success in completion. And we could use a double-sided reflection here, such as, you were really busy with schoolwork this week, and you were still able to find some time to play basketball. Lastly, the patient may report that they completed their plan, in which case we want to recognize their success with an affirmation, such as, you've worked really hard to achieve this success. Regardless of whether or not the patient completed their plan, we can then ask them what they would like to do next, which brings us back to the beginning of brief action planning for question 1. So sometimes when using motivational interviewing or brief action planning, you may encounter some resistance.
Oh yeah, actually it worked. Mm-hmm.
If this is the case, there are some things you could do. The first would be to make sure the plan is manageable for the patient. Another thing you should do if the patient is showing some resistance is screen for depression. Because depression may interfere with the patient's ability to complete the plan or be impacting his or her motivation. If they are depressed or do screen positive for depression, it may be helpful to then refer them to somebody who specializes in mental health. We also want to keep in mind the PACE acronym that represents the spirit of motivational interviewing. So just as a reminder, that includes partnership, acceptance, compassion, evocation. And then lastly, and this is my favorite one and one I think is most important, is we might just have to accept that the patient is not yet ready to change. So here we have a video of applying motivational interviewing and brief action planning in practice in pediatrics. In this video, you'll see a 10-year-old boy named Ravi Patel, who is having his yearly well checkup exam with his doctor, Dr. Lee. He has a strong family history of type 2 diabetes, and his mom expressed her concerns about Ravi's risk for diabetes. So in this example, you'll see how Dr. Lee incorporates brief action planning into their appointment.
Carli, is the video still showing?
Yes.
Okay,
Can you
great.
see it? Are you able to see it?
Yes, I don't see that it's going. But if it's showing on your end, that's fine. We're just having some technical difficulties.
So as you can see in the video, Dr. Lee used great open-ended questions, often asked permission. You could see that Robbie didn't like the ideas that his doctor had suggested, and also didn't know what he wanted to do for his health. So to be able to express or suggest more suggestions, give more suggestions that helped him spark an idea. And so he decided to drink less sugary drinks. Initially, his goal that he set was lower than a 7, and because of that, they worked together to increase his confidence and ended up getting him to a 7, which was great. And after that, Dr. Lee was able to ask him permission, or if he would like for her to contact him following the appointment just to see how he's doing. And once that was done, they even set up a specific time, which was great. So in conclusion, the focus of motivational interviewing is on evoking the patient's motivation for change rather than our own reasons why we think they should change. Brief action planning is a brief and structured technique that uses principles of motivational interviewing to address many health behavior challenges that are commonly encountered in primary care settings. While motivational interviewing skills are easy to describe and they can make intuitive sense, they can be difficult to master, and it takes dedicated practice and commitment to employing this approach to feel comfortable with it. So thank you very much for your attention. I think Laura is going to hop in and say a few things about CPAN, and then we are open for any questions.
Thank you so much for your presentation. My apologies. We're still trying to work on that glitch with Teams. I'm going to talk with our presenters and see if there's an opportunity to present this again. We had a lot of people that were moving into this meeting a little bit later, and we want to make sure that there's an opportunity in the future to hear this again. what I'd like to do is at this point, if there are questions, I would certainly like to open up your questions and have our presenters answer those. You can definitely add your question in the chat and we can read that to the presenters. All right, no questions right now. So, question, what does OARS stand for? And can you explain that a little more, please?
Yeah, so OARS is actually a really helpful acronym that touches on each of the core motivational interviewing skills and how to respond to a patient. So the O stands for open-ended questions, the A stands for affirmations, R for reflections, and S for summaries. So you start out with open-ended questions, which really serve to elicit the patient's internal motivations for change. And those are much different than closed-ended questions, which are shorter and typically can only respond with a yes or no answer. And then you affirm the patient to support them for what they're doing. You reflect what the patient was saying to make sure that you have a good understanding and you actually know what they're saying. And then summary, just to wrap it up, to understand, to make sure that you guys are on the same page.
Great. And so would you give maybe a couple of examples of affirmations? And the reason I ask is when I was learning about motivational interviewing, I didn't really understand an affirmation that would really impact the individual. I think about, you know, boy, that's a nice hat, or you did a great job. So how would you turn "you did a great job" into an affirmation?
Yeah, so to me, affirmations really acknowledge that the patient is trying. And some examples include, you're doing a, I think that you can just say you're doing a great job. Do you find anything wrong with that?
You can also be more specific if you want to be.
Yeah, you're doing a great job eating healthy. I know that it's difficult.
I really appreciate you sharing that with me. It encourages a close, comforting relationship without judgment.
It always feels good to hear that positive reinforcement. And make sure that you're even understanding them accurately.
Great. So when you talk about reflections here, talk about simple reflections, you talk about complex reflections, you talk about amplified reflections. Is there a way to really differentiate and support that with some examples?
Yeah, so simple reflections really just basically include repeating and rephrasing what the patient said. So for example, if we're talking about a patient wants to stop taking medication or is ambivalent about whether or not they want to take this medication for the rest of their life, you could say something like, you don't plan to keep taking your medication anymore. It's very basic. You're just basically repeating what they're saying. And it gets titrated, it's a hierarchy. So complex reflections are a little bit more in depth, and they include reflecting that emotion or meaning. So for example, you could say something like, I can see it makes you feel really angry when your mom tells you to take your medication. And then amplifying reflections, they add more emphasis and meaning to what the person said, goes a little bit more in detail. So an example would be, you would rather stop taking your medication, even if it might mean you get a little bit sicker. And then a double-sided reflection acknowledges that sustained talk while integrating it with previously identified change talk. So you're looking at both sides. They want to change, but they're on the fence, and you're highlighting that ambivalence. An example of that could be, you're feeling concerned about the possibility of needing medication for the rest of your life, and you've noticed that your mood's improving when you take it. So it helps for the patient to hear both sides of the fence.
And shows that you're listening too.
Excellent, thank you. There was another question, and what about BAR? B-A-R.
I'm not. Oh, do you mean brief action planning?
Well, it says in here, what about BAR? Maybe it was BAP?
I'm not sure what BAR is.
BAP.
Oh, BAP.
Perhaps PAR?
So, I mean, I'm thinking you're thinking of brief action planning, which would be BAP, possibly. Is that correct?
Lori, does that sound right? It was mentioned in your summary.
Then yeah, that should definitely, let's see, be your brief action planning.
BAP. Okay, there you go.
So brief action planning was the steps that we went through. Here's the outline of it. And it's just a really great way for a primary care provider to help elicit or work with change talk from a patient. And it's the way that you do it that's not giving advice. It's very much patient-centered and doing things on the patient's time. And what I like about it for primary care providers is that it's really structured and gives you a pretty good outline of what to do and even what to say.
Great. You know, motivational interviewing has had some changes in the verbiage that have been used. I think about in many years ago, motivational interviewing, it was almost parroting back what that individual said. I heard you say so-and-so, or affirming, almost using the exact words. So can you share with the group why that's changed and how much more successful motivational interviewing has been when it's been changed to the new ways of connecting with that person and affirming that person?
Hi, Laura, I can take that one. I think elements of that are still in existence in motivational interviewing. And I think stylistically, while motivational interviewing has these core skills, it is dependent largely also upon the practitioner and how they word things. So certainly some repetition and presenting back to the patient of, you know, their own sustained talk or change talk is important, as well as providing new content in our reflections. So, you know, as Olivia mentioned, we may reflect that a person feels angry, though they haven't explicitly stated that. And that can really help build rapport and help someone feel understood and that the clinician is empathic. But what we want to be careful with in motivational interviewing is that the clinician is not the one providing the change talk to the patient or providing the solutions to the patient. And so I think some of that is where that repetition comes in, is that we want to make sure we're really drawing out the patient's own motivation for change and own strengths and resources and presenting them back to the person. And then really building on those things rather than focusing on deficits or the ambivalence that the person is experiencing, if that makes sense.
Sure. So Dr. Ross-Young, to kind of add to that, you know, the providers that we've sent this to work with children and adolescents all the way up through age 18. And I'm wondering, how does a provider use motivational interviewing maybe with a 17-year-old versus how that would be different with maybe an 8-year-old? They're so different in their developmental stages.
They are, and I think, and I think also in some ways that kind of appropriate sense of rebellion and independence is growing, right, in an 8-year-old just as it is in a 17-year-old, but it might be expressed a little differently. And so with a 17-year-old, I think it is important to ask permission and to really collaborate. There's a natural urge to kind of push back against authority that's appropriate for that developmental stage, and feeding into it can damage therapeutic rapport and be less effective. Additionally, for an 8-year-old, if the child is at a cognitive level where they're able to engage in a little bit more of verbal psychotherapy, motivational interviewing could be something that is helpful. Additionally, more behavioral strategies for younger children. So focusing more on what they are currently doing and what options they might like to try for change. Even 8-year-old kids really know what they like or what they'd like to try. And the more that we can bring them in on the planning and the decision making, and the more that they have that sense of authority or involvement in their own treatment planning, the more likely that anyone, really regardless of their age or developmental stage, is to participate and to follow through on it after our sessions.
Well, it's great to hear that it can be used in, multiple ages for providers that are serving children and adolescents, and those that are at different developmental stages. So as we begin to wrap up our motivational interviewing presentation today, if you could give maybe just some final words of wisdom for folks who have never used motivational interviewing, how maybe you've seen it make a difference in the success of patients in making change, and starting change talk when maybe they didn't even realize there was a problem, and using that motivational interviewing started them making change because they wanted to make change.
I can start that off, and then we can kind of each share our perspective. For me, I think times when I see motivational interviewing work is that as a psychologist or as a pediatrician or a psychiatrist, sometimes we feel an urge that we know what's best for the patient, or we have a very strong opinion about what they should or shouldn't do, which can lead us into a debate or an argument with a patient. And that's never effective, not only because it puts us at odds rather than putting us on the same team, but because the patient is then the one coming up with reasons to argue for maintaining an unhelpful behavior. And so we're really kind of shooting ourselves in the foot by, taking such a firm stance. And so I think by exploring rather than arguing, we're allowing the patient to also generate some, examples or reasons that they might like to make a change rather than just giving us that sustained talk. And I would also say it's helpful because people often feel stumped when they meet with someone who says, I don't have a problem. I don't need to be here. I'm not going to get anything out of this. And using some of these motivational interviewing strategies can help us elicit any sort of change talk, even if, as my colleague mentioned earlier, the change talk at this time is, I want to get my parents off my back. Okay, that's still change talk. What would it take for your parents to be off your back? What would it be like if they weren't on your back about, XYZ behavior? What would be the pros or the cons of that? And so instead of getting stuck in arguing and trying to convince the person that they have a problem, we're meeting people where they are and eliciting some of those their own responses and rationale. And so I think those are two areas for myself. I'll let my colleagues also maybe share some things that they've noticed in their own practice.
I think it's been really cool when you go up to a patient and they're kind of expecting you to give them a talk about medication adherence, like why aren't you taking your medication, things like that. But instead you come up to them just being curious, just with an open mind, not trying to tell them what to do. And it's cool to see how they start to relax and then are able to see how maybe taking their medication could be a good idea. They're just not on the defense, which is really nice.
And I've recently found motivational interviewing to be really efficacious with some of my teenage clients, especially my teenage male clients, because they navigate this world that is so rigid, and I guess there's all of these societal expectations set out already. So people are telling them what to do, and within those teenage years, they're changing biologically, socially, just so many changes. So giving the patient the power and the autonomy is, to me, the foundational aspect of motivational interviewing. So I provided an example in the slides talking about a teenager who doesn't want to wear a condom. And that actually happened to me in real life. He's had all of these adults tell him, you need to do this, or this is what happens. So it's giving them that freedom to explore the reasons why he doesn't do it, maybe the advantages and disadvantages, and then coming up with this plan on his own that he's going to be more likely to follow, rather than me just saying, you need to do this because X, Y, and Z. So it's really, really beautiful and cool to see the process unfold organically, because it is patient-centered. So that's kind of my experience with it.
And would you say that it takes time and practice to become proficient at motivational interviewing?
I'm so sorry, Laura, I missed the beginning of the question. What?
Yes, would you say that it takes time and practice to become proficient at using motivational interviewing?
I would say absolutely. I think on paper, it looks like it's pretty simplistic, but for me, I struggled with it, especially at first.
It just doesn't always feel natural, where providers like to help people, so to go in and not give them advice can feel weird, and then asking them to elicit a commitment statement can feel weird, but eventually it gets more natural.
Yeah, as providers, I think that, I can't speak for everybody, but I know, I went in this field to help people, and you can't be a fixer really in motivational interviewing. You have to consciously and consistently take a step back and allow the patient to lead the way as you kind of just guide them and support them on their journey.
Right. It's not about where you want the patient to go. It's about where the patient wants to go.
Excellent. Well, we really appreciate your time today. There are so many questions that folks could ask. Sometimes we just don't even know what questions to ask. So what I'm going to do is put up our CPAN slide today to share a little bit more about our program for those that are not familiar with it. And would we be permitted to share this presentation for those who attended and maybe they didn't get to hear everything?
Yeah, definitely.
Okay, great. And then again, we appreciate your time. Let me share my screen here real quick. All right. So for those who are not familiar with the CPAN program, this is the Child Psychiatry Access Network. It is a consultation, referral, and resource program that is funded and supported by the state of Texas for PCPs who serve children and adolescents throughout the state of Texas. UT Health Science Center is the hub for Northeast Texas. If you are located in another region of Texas and not in Northeast Texas, there is a hub that serves you. The entire state, 254 counties, are all served by this service. If you have questions, if you'd like to enroll, there's information on this slide. Please feel free to give us a call. We can share more information with you. Again, it provides consultation for PCPs who work with children and adolescents that have mental health disorders. You'd have an opportunity to speak directly with a child psychiatrist. We can also help find some of those really tough resources as close to the family as possible. And we look forward to being able to serve you. Registration is super easy. You can enroll by that QR code, You can give us a call, or you can go ahead and email us at cpaninfo@uthct.edu. Now I'm going to go ahead and share the QR code here for you. One moment, please. All right, are you seeing the QR code for today's presentation to receive the CME credit? Okay, great. Thank you very much. So we appreciate you being patient with us today. We typically don't have technology issues, but you know what? Every once in a while, there's going to be a gremlin in there. So I am going to see if there is a way to have this presented again, do a reprise of this presentation for those of you who did not have a chance to hear the beginning of it. If you're interested in receiving the slides from this presentation, if you would email me at cpaninfo@uthct.edu, we will get that presentation sent out to you. And we will also be completing the CME credit attendance certificates here in the next week or so. I'm going to leave this on the screen for a little bit longer, but I would like to open up the floor for any verbal questions you might have here in the next couple of minutes. Is there anybody who would like to ask specific questions to our presenters? Okay. Well, I want to thank you all for joining today. I'm going to give you back about a minute. Please complete the presentation evaluation. Again, our apologies on the technical issues on this side, and we will do some research to identify what the challenge was.
Thank you.
Have a great day, all.
Thank you.